Thinking of folks from Boston when they did that, 2 R's, 4 letters, it's not easy. So Order specializes on the visibility and security of medical devices and other assets within healthcare organizations. But my real job here is to introduce Juhan Sonin. Johan, you have creative sandpaper. I'm not sure what that title means, but that's cool. But Juhan specializes in healthcare design and system engineering. He is the director of Go Invo. The studio designs helps 700,000 Massachusetts residents receive food stamps, are used by Wikipedia to explain complex health concepts and manage care plans for 150 million US residents. His work has been recognized by the New York Times, Newsweek, BBC International, Wired Magazine, National Public Radio, and published in the Journal of Participatory Medicine in the Lancet. Juhan has spent time at Apple, the National Center for Computing Applications, MIT, and MITRE, and he currently lectures on design and engineering at MIT. Where is Juhan? Welcome up. Oh, there you are. So, see what happens when I take my glasses off, then I can't see. Thank you.
Good afternoon. Bios are usually the illusion of accomplishment, so I'm always iffy about those. But yes, I do pretend to run a business. I also teach at an institution that's not Harvard. And just for people to know, here are some of my disclosures. I am obviously not a good investor because I sold my Apple stock when they were in the teens. But I don't touch that at all, and all my entire healthcare record and entire genome is all open source, for better or for worse. If you want to get a hold of me, feel free. I'll try to get back to you within 2 business hours, give or take a few minutes. So, years ago, decades ago, centuries ago, this is a good sentiment. Now, we're hearing much more about it being a business, and that's true, but I like the sentiment of decades ago about where medicine is as a profession. Yep, it's noble, but people use that nobility ethos, I think, to get their own way, and I think money is one way that we need to look at healthcare industry today and what's happening with it. If you look and do a little square around Harvard, MIT, and the other crews in the Cambridge area, Juan Enriquez has this stat where that basically occupies 25% of healthcare GDP. That is a huge, huge number. Probably way too concentrated of a number as far as I'm concerned. I don't think that's necessarily healthy. And when you look at it globally, that's 1% of global GDP. That's a lot. So, I want to look at one case where I think this is a clear indication of problems erupting that happened at Sloan Kettering. It's a very good cancer institute, and they had, until recently, a cat at the CMO level, Jose. He's the CMO. Let's talk a little bit about how he was operating his department. There are a lot of conflict of interest rules that he blew through. You can be on advisory roles with PharmD and other crews, but when you have an ownership stake in those drugs, that's a potential conflict of interest problem. Let's continue. He also received payments for cancer research that he published in his journal. Oh yeah, let's talk some more. He publicly advocated for these drugs by the company he was on the boards for, by the people he was getting paid for, and getting serious cash for it. Not so good. So, let's look at this in a little bit of detail about what happened and potentially what we can do about it. Page.ai. People familiar with the case? We should be, because this is happening everywhere. It's not just at Sloan. It's happening at Mass General. It happens everywhere. Where this company that came out of the lab there was using patient data, unrestricted basically, but yet it's mine, right? My data supposedly, but the hospital really owns it. And a lot of people worked on that, getting that data. It wasn't just the patients, it was also all the blood work that had to be done. Were they in the loop on this? No. And the equity stakes in the company were all attached to those at the top of Sloan Kettering. Let's keep going. Well, work by many, over decades of work by pathologists were used. Again, it's my data, your data, and thousands of people's data at use without understanding that there was a profit-driven nature to this particular use of the data. And anonymity, I don't think, exists anymore, and I don't mean to be flippant about that, but that's a whole separate conversation. We have to be careful about it. And there's this gold rush in .orgs now even that's infected them, that there's a lot more than just doing good and getting paid for it, but really want to get paid for it. And there was no competitive bidding either on the data set. So the company was born there, they bid inside the firewall, and they got access to the data. Now, it's interesting, his name is hiding in plain sight, it's the main guy there. It's always interesting when you're an intern and a CEO at the same time. But the more important part is that the data use agreement keeps patients out of control by design. So, what kind of design is this? Well, right after this was exposed, not after it happened, but after it was exposed recently, the CEO and the CEO had a sort of rather blasé answer that, well, it was hard, it was sort of chaotic, yeah, we have robust things, but it's nebulous. This is actually the response to their oversight. This is a crime. So, hospitals, they own the data. Typically, I think they're across the US, the law bends that way. I think there are 15 states which actually have it in law, and the rest slide that way. Patients don't have ownership rights on their data. The IP is owned by executives, yet it's funded by who? Our tax dollars. Our tax dollars pay for this. This is corporate welfare at its finest, if you're a Ralph Nader fan. And for me, I think there is a brutal instinct here which has happened over the past few decades where it's the rush to money above all else. Now, you know, this is, for me, ethics is situationally optional. Again, it happens everywhere. MGH, it happened with ADHD and bipolar kids, and J&J and others. So they're not alone, and it's happening all the time. These are just cases over the past year and a half, other than the MGH one. So we are complicit, though. As human beings, as patients, we're there because we're pushing data everywhere. We have our devices. We have our information everywhere, and it's just going to Kendall, to Palo Alto, and to everywhere else. So what the hell are we pushing there? Well, I mean, health data, this is one way I describe it. This is on Wikipedia. This is what we seeded this article. It's any information about me that has to do with making decisions about my health and wellness. And usually you see this kind of diagram. Again, we did this too. All the diagrams, by the way, I'm showing today are open source, and we've created them for the most part. This is what most clinical aspects of healthcare look like in terms of where your data is, but it's much more than that. And you also have to look at who uses it. We don't have any law around protection of that data when it comes to where it goes after the hospital. So you probably know that there's a provider group or a pharmacy or a lab or an insurer. It goes to the EHR. It goes into the EHR. It goes to PBMs. It goes to banks potentially. This is a long, winding road of your data getting munched on without you know about it. There are potentially up to, if you're using Alexa, for instance, now that's not particularly the best example, but I'm just giving you one. If you're doing a PRO through Alexa, there are potentially 800 different little services that touch your data through that stream. It may be 2/3 of that through an EMR, okay, that ultimately touch your information. If you're really interested in this, there's a well-researched book about on our bodies, our data. I'm not quite sure I love the fact that he's taking the women's movement here to use this, but Adam Tanner's at Harvard, so you can talk to him there if you're interested. But it's more than just your clinical data, right? This is, for me, your life data, all the parts that happen to you. My salary is a health data point, right? As you heard Danny talked about SDOH this morning. So my contention here is that in this age of surveillance, that it's possible that owning it, that patient data ownership, will turn this into a net positive. So how? Well, this has been talked about for a decade or so or more that I know of. Blumenthal talked about it here last year at the National Academy of Medicine. They had a whole session on it. And several high-profile people have actually talked about it. You heard Mickey say, oh, yeah, SEMA has talked about it as well. I haven't seen any policy from either of these cats on that. I'd like to see that. But I want to make sure that this is clear about what kind of ownership we're talking about. It's not about my home. This is how we're starting to seed the bill for the state of Massachusetts. These are some of the main points. Because law is where shit happens, unfortunately, or fortunately. But patients should co-own or fully own every health data about themselves. One. Second tenet is, if I generate it with my clinician or the hospital generates it with me, that's co-owned by both parties. And then when I do it all myself, no, it's mine. I generated it. This is like common sense. If you really want a primer on this, there's a 2-pager and a 14-page version of this. George was left out because JAMA has this funky rule about only 3 authors, whatever. But it's a great piece, and what they outline are 3 components that you need to get this done. You need common data elements. That's something that we still have trouble with in this country. We like to talk about APIs. I'm all about, hey, great, we can communicate, or at least the tube. We can describe the tube that the sludge goes through. But at the atomic unit, you need to define the data at the element level. That's where interop happens, and so that's the first thing. The second part is you need a receipt. Every time your data gets smooched, kissed, whatever you do with it, you need a receipt of that happening as a patient. You may not want to collect all of them, and they may be digital or whatever it is, but that's a separate conversation. And then you need a contract. That contract needs to negotiate what happens with that data. And then that gives me ultimate control over my longitudinal health record. So, just the premise here is that you have an encounter, whether it's at home and you're in your jammies, because health happens at home. Notice how like things are 8 to 8. What the heck is that? But okay, so it's happening at 2 a.m. I should be able to get any chief complaint in the world, responded to in 5 minutes. And so when I do that, or let's pretend that fantasy exists, there is some patient data use agreement that says, here are the rules for my engagement with you. Okay? Now, this sounds complicated, and it currently is, because we need to design a much better and more lubricated WD-40 way of doing this without you having to have a lot of overhead. But I want to give you, as people who are in healthcare, sort of the nitty-gritty. And then there is this patient data manager. This is all open source, by the way, and we're building a prototype of this now. This is in the primordial ooze stage, but I'll walk you through it. There is some manager that allows you to pick apart and put together what just happened to put it into a data receipt. Here's what happened. You get this on your phone, whatever device you use, that ultimately then populates your patient health record. So this is almost like Tetris, right? You have all these things coming in. You heard previously, it's not necessarily you at the center. You're more in the driver's seat. But you need control and ownership in order to get that to happen. Okay, so you can also then, I think, one byproduct of getting this kind of data at the data element level is clinicians will understand or see how full is the record, right? Right now, you assume there's nothing in it. For most patients, there's very little. But over time, you'll be able to see, well, is the record full or not, or somewhere in between? There's some continuum here. This is one byproduct of having this kind of structure, just one of many. Not everyone, in fact, very few people are going to have no one's really going to get to full data records. So, as a side note, it's amazing. It's taken years and a ton of overeducated academics to tell us, as of last month, that drawing pictures helps understanding. Well, no kidding. But the reason why I show these pictures is it helps storytelling and it helps you lock on. At least they may or they may not, depending on who you are. But I think this is an undervalued output in academics and in science and in healthcare in general. So yes, we do a lot of this. This is for George Church's group, and you can quickly see what's happening. CDC has used this as well, this kind of technique. for showing what disease is, and it's come out very well because then people get it. So using that kind of technique to let people understand how patient control and ownership works, here's an example. This is an open source project. It's called Patient Data Manager. It's on GitHub. It's just being born. So this is how we're going to show the story. It's your data. We just happen to manage it. Get to know your rights in just a few seconds. You own it. That's really all you need to know, and you have it. You can get it from anywhere. You can get it from any who, and put it in some place that I can see and use. Get this orange wall of brick data. I'm not sure that is the best analogy, but it's the kind of current story. Mistakes happen. You need to be able to edit. You need to be able to correct it, comment it. Share it with whoever I want. It's mine. Don't tell me who I can or cannot share it with. You can share it with science for research. There's a break the glass model that needs to probably happen. I'm stuck to a curb somewhere, and someone uses a spatula to lift me off. You probably need to know what the heck's happening in my life. Maybe TMI. You can review who can see it. There's an audit. You can stop data sharing. Yeah, you can do that. And now, as part of engaging, though, most likely they'll keep a copy, right? So you cannot stop businesses. You cannot stop how operations work, but you can start to control it. You can delete it from the patient data manager, and you can transfer it without them having a copy. And they're responsible for its responsible use and safekeeping. So that is how we're starting to sort of at least prime the pump of getting people involved, at least through this little service. But we need a true way of looking at it before we actually get it into law. So we have this working with HealthKit, and I'm just going through this for you. So I land on HealthKit and I turn it on. So they have access, meaning my local phone has it. And I just got my colon cancer care plan. This pops up as part of HealthKit, and now I get to see all of it. Heck, I get to see an actual care plan. I actually get a receipt of what just happened during my last episode with Danny Rask, right? Not this Danny. And I get a recording of what happened in that session. When you're being told things about your cancer diagnosis, you'll probably forget. It'll be a wash in the encounter. I want to know what happened. I want to be able to rewind it. I want to be able to see it. I want to know what data is going to be in it. Okay, this is how I want part of healthcare to work. If I slide down, maybe I can see, what someone mentioned this morning about the social determinants of health. What data around that do I have? Do they have access to? It's all right there. This is how I want it to work. Now, there's a lot of text here. And so I'm not going to ask you to go read all this. The paper gets updated, I believe, on Tuesday next week, so you can download it. I'll give you the URL. But additional things to think about is that, maybe our patient data ownership should work like copyright. After 50 years of my death, or whatever it is, what happens? Does it go public domain? I don't know. I don't have an answer for this. We need to think about some of the other risks involved. Does public ownership of anonymized data and big databases, do we own it? That may be something to actually seriously consider, considering how much people use that without our knowledge. So for me, this is much more of an affront, not just on healthcare, but on what's happening in the digital space. All of my data is getting chewed on. All of your data is getting chewed on for massive profit. And I think the last part of where capitalism has gone is selling the experience of us. That, to me, is not acceptable unless I say, okay. So I demand patient data ownership rights. And if you want to go, it's a very rough. It's in GitHub, so for those of you wonks that are capable or want to learn GitHub, if you want just the paper, I can send it to you too. So about those machines. Okay. Well, in general, when we use a healthcare service, you have no idea how something operates inside your phone, what the algorithms are doing, what the models are creating. But if the results are okay, you're like, okay, I'll live with that. But part of the issue here is that the discipline, the profession of medicine and health really is about sharing knowledge and about making people better. So this is out of the Declaration of Geneva. And now we have everyone touting that they have 30 million people running in their system. They're risk adjusting for it. Super, great. How does it work? My stuff's in there. My parents' stuff's in there. My kids' stuff's in there. What's happening? That's the answer you get. The hand. We're making money. But the problem is, this is typical of how I would say 2/3 of the U.S. treats their healthcare as a human right. The UN has said as much. Now, if it's so noble, if it's key to our life here, and we don't have a choice, as patients we don't have a choice, right? The thing when you go to a hospital, they say, yeah, we don't have a choice when it comes to patients. Yeah, well, we don't have a choice either, right? As patients to where we go often, we demand that healthcare be open. So the internet is a good representative example, is the infrastructure for it is open source. It's also a human right. Again, WHO and UN have also mentioned that this internet is a human right. It's part of the sustainability goals. Now, if you go really nerdy, I won't stay long on this, but this is like the open system model, OSI model, of how the internet works. And you go from the application layer, which we all have on our phones, all the way down to the physical transport layer. Most of that is open source, right? TCP/IP you've heard of, right? HTTPS, right? OAuth, which is part of Smart on Fire and all these kind of things. Open tools for the planet to use. And yet, we have a cavalcade of great examples of open source that have business models that work. Heck, I think, IBM just bought Red Hat this year for how many gajillion dollars, right? GitHub, you name it. Okay. And yet, in our system of care, in the healthcare IT space, I would hope most of this open source, but no. Most of health IT is closed, other than, FHIR and some other protocols which are licensed under Creative Commons 0, which is an open license for everyone to use. But everything above that, about 99% closed. So Eric Topol likes to say we have an anti-open source healthcare system. Who's doing it well? Well, not that many, but Estonia, my homeland, is doing it pretty well. Now, it's a lot different population. It's a lot smaller. But you know what their overhead, you can see it here. Their overhead for all their infrastructure is what? 1%. Why? Well, there's a lot of reasons for that. But one is their infrastructure on the technology side is all open source. Completely. So they've saved money there, but more importantly, I don't often buy the argument of saving money always on open source, but it is leveraged by other countries that also make it better over time. So Estonia is a very good example of what's happening technically and with the quality of care for mimicking. There are some very good open source projects out there that are existing. Some are thriving, many are. I think almost every single one on this slide I have contributed to in some way. But two I want to mention are Standard Health Record, which is .org, by the way, and Cynthia also. Two excellent open source projects. One about how do you define the key attributes of metrics, and that's Standard Health Record. They have an IG as part of FHIR right now with M-code. It's the cancer definitions. That's really pretty nerdy. And Cynthia, another thing we have a problem with in healthcare is getting access to synthetic data, right? Big swaths of people or synthetic people that you can do interesting experiments on, but they're not real. So Cynthia is an excellent project out of MITRE that does this. So I just wanted to mention two good open source projects. Now, I think there's a need across the health IT board for open source health projects that are not here. I mean, the top three for me, if I had to prioritize, was I want a diagnosis generator. Anyone on the planet can then get it, can use it. Doctors can use it, patients can use it, and make it better and better and better and better. Right? Human DX was starting to get there and is, but most of it's closed. But that's the kind of thing that can help not just the United Statesians, but those who live on Spaceship Earth. Now, you have a lot of people talking about open source. It's still not quite there yet, if you can see the smirk on my face. But it needs to be. because, let me just wrap up with this missionette, is that healthcare and public health are a utility. It's a human right, and it's too damn important to be closed. And we live in this closed ecosystem, right? And all these models that drive the clinical care we're getting are governed by black boxes. And we're actively designed out of the decision-making process, whether we want to or not, in favor of like the corporate optimized care. We've heard of this before, right? And sometimes these biases are built in by accident, right, into the software. Sometimes they're on purpose, like what happened in Indiana with SNAP, right? They were changing the algorithm to not let people actually apply easily under SNAP benefits. How criminal is that? Yeah. So we want these algorithms to be open so that we can interrogate them, because it's my health, it's your health, it's our health, and my life is at stake. So my demand here is that our healthcare services be open to inspect and to correct bias, because I want all of these services to become more valuable over time as more and more patients, as clinicians, as clinics, and governments engage in healthcare for all, not for the elite. You can look at some of my diatribes here, and thank you very much. Any questions? Anyone want to throw a stone? Sure.
Some of your concern about patient rights to avoid sharing their data, I'm concerned about it because, you know, in the past we used to do studies and which select patients, and then we do the study and we publish results based on what we took without much permission, especially in, you know, unless that's an experiment that we're doing on patients, to take data of outcome of studies. We did not, we as an internal review board that did those studies and decide about the outcomes. So if patient now can tell me, I don't want my data to be taken, then the result will be skewed. The conclusion will be skewed. It will be bad to healthcare if I cannot use data. You are concerned about...
Hold on, let me respond to that one thing.
Wait a minute. Let me go to the next one. You're concerned about people that are cheating the system, taking advantage of the system.
They are.
We had it before.
Yeah, we did.
Even with doctor, we have it that the doctor did studies just to get their name.
But it's not okay.
No, it's not okay, but we discovered them over time because we have repeated studies,
Yep.
and then we realized that this study was done 20 years ago by this guy was a crook. Those people don't stay in the system.
Okay, so let me answer your first question. Peace. One, his first question was, well, patients are not going to give up their data. We're going to have a hard time across like an IRB or something like that. Well, one, there are lots of studies of which we've been a part of that say patients across the board want to donate their data to science, right? So I think it's in the 70 percentile that if asked, they will donate their data to that institution through that IRB. Now, once they do that, they often don't get in the rule or in the proposed rule, they don't necessarily get the option of going, well, 6 months from now, boop, you know, I get to opt out. You make that decision, right? One institution or one group of open humans allows you to do that. They're out of Mount Sinai in New York, where you can retract your data. But in general, once you get the data, right, that's a contract, and I have to abide by the contract. So the first one, I think, is just if you abide by the rules of the contract, you'll get to use the data. And then you also have the social public side, which most people want to donate it to. That's why all these programs are really successful. The second question is, what, people will be bad across the boundaries? What was the second question?
Yeah. Do you think that all the companies are going to take the data and just abuse it for greed purpose? I don't think so. I think that some of them will, and we are going to discover them over time by comparing, by seeing who is using the data. Those things will be discovered.
Part of it is you don't know who's using your data. That's part of the problem. And if you look at the economy of the surveillance state that we have, right, most of their revenue comes from the things that we do and put in the system, right? And so I think I have there's a fundamental flaw there that they're using us to generate profit. Now, this obviously requires more a white-lined material and on a mirror to talk about more. But let's talk after if there's anything more. But I don't want to get companies off the hook for abusing our data, right? Yeah, it's still going to happen. But I don't want to keep saying, yeah, that's fine. Good? Okay, thanks very much.